Good afternoon, everyone, and welcome to our 9th Dialogue for Change Invariance conversation series with experts discussing the intersectionality of race, systemic inequality, policy, and the actions that we can take as CEOs, as employees, and as individuals to enact change. I am Maia Hunt Estes. I'm a principal at the firm, and I'm pleased to be moderating this conversation with experts from the public and private sectors to discuss an issue that has personal meaning to me: doing the work to overcome racial health disparities. There's a saying within the Black community: when white folks catch a cold, Black folks get pneumonia. Never has this been more apparent than during the COVID-19 pandemic, which has put a spotlight on the consequences of systemic racism on both the healthcare and quality of life for communities of color. Black people, Indigenous people, and people of color are more likely to be hospitalized and more likely to die from COVID-19 infection than non-Hispanic white people. The statistics are truly staggering. Recent data from the Centers for Disease Control and Prevention show American Indian and Alaska Native people were 3.7 times more likely to be hospitalized and 2.4 times more likely to die from COVID-19 infection. African American people were almost 3 times more likely to be hospitalized and almost 2 times more likely to die from COVID-19 infection. Hispanic and Latino people were 3 times more likely to be hospitalized and over 2 times more likely to die from COVID-19. The CDC has tied increased hospitalization and death rates to long-standing inequities related to the social determinants of health, including economic instability and lack of access to health insurance and lack of access to primary care. And just this month, the CDC director said racism is a serious public health threat. And as we have all endured this pandemic, it has become painfully clear that people of color are suffering at exponential rates. So many of us have a personal story that illuminates how prevalent health disparities are. I want to take a minute to point out the background that's behind me. It's an oil painting of my father, completed when he was a student at Howard University. During the pandemic, it's been a comfort to glance on the screen and to see him. He passed away a little over a year ago on April the 8th, just as we were beginning to grapple with the seriousness of the global health pandemic and when we were still learning about its dangers. As his only child, I worried about his exposure to COVID-19 because in addition to being a resident at a nursing home in Montgomery County, he suffered from many of the underlying conditions: hypertension, diabetes, history of stroke, and a history of heart attack that we now know make the coronavirus a serious threat to his life. To make matters worse, he was living in a nursing home where I could no longer visit him. So instead, we talked almost every day, and I quizzed him with questions. Was his temperature being taken? Yes, he said, every time he went to the exercise class or every time he went to the dining room. Were aides wearing gloves and were they masked up? Some of them, sometimes, but definitely not all the time. I asked, had he been told if any of the residents had coronavirus? No, he answered. No one had COVID-19. Had he been tested? No, he replied. And when was I coming to see him? Which was his echoing refrain and question that he asked me most often. 2 weeks following his death in early April, Maryland finally required nursing homes to provide information on the number of cases in each facility. At his nursing home, 15 staff and 18 residents had tested positive for COVID-19. My stomach dropped, and I wondered who was going to advocate for this vulnerable population of mostly Black and brown people to make sure they received the highest level of care. Who would advocate for the safety protocols and the equipment for the workers in the facility, many of them immigrants who staffed the facility. It reminded me yet again that as we move through this coronavirus epidemic, that Black and brown people, people of color, and those in a lower socioeconomic status were going to carry the heaviest burden during this national health crisis. And it also reminded me that communities of color would need strong advocates. Well, I can tell you this, the panelists that are joining us today are among those who stepped up in a big way. And I'm grateful that they've used both their voices to advocate for policy to make positive changes for these most vulnerable communities. In short, these panelists that I'm about to introduce you to have done the work to end health disparities and to put a spotlight on how health disparities affect health outcomes for most vulnerable populations. And they continue to do the work. So with that, I'm excited to introduce and welcome our panelists. Congressman Lauren Underwood serves Illinois' 14th Congressional District. She founded and co-chairs the Black Maternal Health Caucus. Congresswoman Underwood is a registered nurse who, prior to Congress, served as a senior advisor at the U.S. Department of Health and Human Services under the Obama administration. Tammy Boyd is the Chief Policy Officer and Senior Counsel for the Black Women's Health Imperative. She previously served as a managing partner for TKB Global Strategies and Watts Partners, and she worked at Johnson & Johnson. Tammy also served as legislative director for the legendary Congressman John Lewis. Dr. Gary Puckrin is the president and chief executive officer of the National Minority Quality Forum, which he founded in 1998. He has taught and lectured at Roger Williams College, Brown University, Connecticut College, Rutgers University, where he was a tenured member of the faculty. NMQF just wrapped up its 19th annual conference on health disparities and the Health Brain Trust, co-sponsored by the Congressional Black Caucus and the American Medical Association. Thank you to each of you for joining us. So with that, let's get started. Let's start with asking each of our panelists if they could provide a personal reflection on what is needed to achieve health equity for all Americans and why the fight for racial justice must address healthcare disparities. Congresswoman Underwood, we'll start with you.
Well, thank you for having me. Hi, everybody. I'm so glad to be on this panel with each of you. So, the journey of health disparities in terms of prominence in this country, I feel like went from let's study it, to, let's set a goal without resources, but let's set the goal and publicize that goal, to now we're in a moment where, we're funding a lot of work in the name of health equity. But I have not heard the decision made that says we will not go back to what was normal, right? And so now we have the opportunity to affirm that Black people and people of color should not be the first to die in a pandemic, should not be more likely to die of chronic diseases, right? Like, we are spending huge sums of money making these incredible advancements in public health and in our just healthcare infrastructure in this country, right? We're investing in innovation and, demonstrating to ourselves and to the world what we can do as the American people. I am hopeful that as we move through this recovery phase of the pandemic and continue to work with our partners in the Biden-Harris administration, that we will see that same type of affirmation, which is that, people of color and medically underserved communities should not be just more likely to die and have that be received with a shrug, right? Like, we need to change that, I think, culturally in this country, so that it's not just limited to a COVID conversation. It's part of our whole approach to healthcare.
Thank you, Congresswoman, for helping to identify that we need to shift the lens in the way that we're thinking about this. That's really helpful as a level set for this conversation. Tammy, you're up next. Same question.
Okay. Yeah, so absolutely, I agree with Congresswoman Underwood. Definitely in the healthcare community, we have known that health equity, that these disparities exist, and COVID has just really highlighted many of these disparities. But I do agree, we do have a unique opportunity now to address those health disparities so that we are prepared as we go forward, and then after the pandemic. And so one of the things that Black Women's Health Imperative did was not only we had several COVID conversations early on about just making sure we got reliable information out to Black women. But then also from those conversations, we released a guide called COVID-19 Surviving and Thriving. And just what do you need to do in order to just survive this time. And then also we, a part that's probably often overlooked is just the mental health and the self-care aspect. But for Black women, we found in our networks and things that we were hearing that, for example, they were the essential workers, so they were exposed more so to COVID, but then also they were the first in terms of unemployment. And then also many of them are the financial supporter of the family. So that would impact it as well. And then overall, again, the mental aspect. So just in terms of health equity, again, it's always been a part of particularly sort of cut my teeth in Congressman John Lewis's office, working with health equity issues and really just bring them to the forefront and addressing them.
Now, we look forward to delving into this conversation, Tammy, to hear more about the resources that the Black Women's Health Imperative has brought to bear, and more about the resources that are available. Dr. Puckrin, you're up next.
My doctorate is actually in history, and I published a magazine for Smithsonian for about 10 years. And one of the things I learned in publishing the magazine, there are about 38,000 zip codes in the country where people live. 70% of African Americans live in 2,500 zip codes. And back in 1998, when we got started, no one was collecting data on those 2,500 zip codes. I mean, we were talking about health disparities, but we didn't have the data. So we decided that our contribution to the whole discussion around health disparities was to collect health data. But we decided that we were not just going to collect it for those 2,500 zip codes, but we were going to collect it for the whole country. So in the last 20 years, we've built a database now north of 5 billion patient records. We collect data on about 160 million lives a year, covering about 72,000 conditions. And I think the big takeaway that I've had in living through all of that data is that at the end of the day, we need to manage patient risk. Anybody who comes into a health facility by race, gender, age, sexual orientation, the expectation is that the health system is going to lower their risk for hospitalization, lower their risk for ER visit, lower their risk for disability, lower their risk for mortality, while improving the quality of their life. No one expects when they go into the healthcare system that it's actually going to elevate their risk. And in fact, the problem is right now is that our healthcare system is elevating patient risk. Some of it we see by way of disparities, but what's happening is that the healthcare system is managing financial risk. It's paying more attention to financial risk than it is paying to patient risk. The Medicare and Medicaid program have no models really to look at managing patient risk. And so what we think is most important about the health disparities movement is to begin to push the system to manage patient risk and move it away from financial risk. And the point is we have the number, we have the data, we can do it. It's just a matter of will. And what we saw in COVID was lots of people wanted to manage financial risk. If you remember, back in June and early July, they wanted to open up the society. They didn't manage how many people died, and some of them actually said it because they thought that managing the financial risk was more important than managing patient risk. And so that's what got us into deep trouble in July and August because we opened up the society too quickly. And so, at the end of the day, we think the basic formula is let's manage patient risk. Let's pay attention to that. And we think that we can address disparities.
Well, Dr. Puckrin, you gave me a great segue as I began the conversation with Congresswoman Underwood. When you talk about Congresswoman Underwood, you founded a few years ago, you founded the Black Maternal Health Caucus. And we know that unfortunately we have an epidemic and a crisis within our healthcare system where the system itself has not properly manage the patient risk for Black mothers. So Congresswoman, if you could talk a little bit about the work that you and Congresswoman Adams, but that you have done in Congress to advance policy solutions that can improve maternal health outcomes. And then if you'll also talk to us a little bit about what challenges sort of remain.
Sure. So in the United States, Black birthing people are 3 to 4 times more likely to die of a pregnancy-related complication than their white counterparts. For every death, we have 70 near misses. And these are disparities that have persisted my entire lifetime. I'm 34 years old. And so after losing a dear friend of mine in early 2017, her name was Dr. Shalon Irving, I knew that when I got to Congress, I want to work on this issue. And I'm so grateful to be able to work with Alma Adams every day with our Black Maternal Health Caucus. And so we have been working to comprehensively address maternal mortality and save moms' lives. We introduced the Black Maternal Health Momnibus Act, which is a comprehensive suite of 12 bills addressing everything from social determinants of health and climate change to workforce issues, both growing and diversifying the perinatal workforce so that all moms have a choice in who they see, no matter where they live, what language they speak, cleaning up some of the data collection issues, pursuing telehealth with this lens of equity and making sure that, there is a robust evidence base that suggests that, telehealth could be a good intervention to solve for maternal mortality. And then we have some COVID-related bills in the Momnibus as well. So there's lots that's in there. I mean, we're talking about incarcerated moms, veteran moms, right? There's just a lot. It's evidence-based. It's bipartisan. 3 of the 12 bills are bipartisan, which we're very excited about. Our Veterans Bill, the Protecting Moms Who Served Act, our Mental Health Substance Use Prevention Bill, the Moms Matter Act, and the Tech to Save Moms Act, which is the telehealth bill, are all bipartisan in this Congress. All 12 bills have been introduced as standalones in the House and in the Senate. We're up to over 130 co-sponsors between the House and the Senate. And so we're making some good progress. I mean, we just reintroduced this about 6 weeks ago in February. So folks are ready, they're excited. And Senator Booker is our new lead in the Senate, and he's just been wonderful to work with. Now, in the meantime, right, we have our original Senate lead, then Senator Kamala Harris, now Vice President in the White House. She has been a tremendous partner, even in the White House. We heard an incredible White House proclamation marking Black Maternal Health Week. They had a roundtable, right? We've been able to include a postpartum Medicaid expansion in the American Rescue Plan. Robin Kelly had been doing that work in the House for a long time. This is an important advancement because the Medicaid program pays for 2/3 of all Black births in this country, right? And so if you're able to extend the healthcare coverage for mom from 60 days to a full year postpartum, that gives an opportunity to connect her with care during a very, very, very vulnerable postpartum moment. That's important. But because of the nature of this disparity, which persists regardless of income and education level, regardless of geography and insurance status, regardless of prenatal care, you can do everything right, but as a Black birthing person, still be more likely to die. We know that Medicaid expansion is not enough, which is why we have the Momnibus. So we're making good progress. The president just unveiled the American Families Plan yesterday in his speech, and in there left some space for us to include some Momnibus provisions, which is extraordinary. So we are working hard, like right now, to try to figure out what can go in that package and what could get signed into law. But this is something that's like happening, which is so exciting, right? To get this kind of support and recognition that this is a problem that we're committed to solving.
No, that's really exciting work that you guys are doing. And it's heartening to hear that you have support of not on both sides of the aisle in Congress, but also that you have the support of the White House and the administration as well. And so, we will all certainly be watching, and it kind of leads me to the next question, which is for you, Tammy, which is, you know, look, we've already in the beginning of this conversation, you know, understand and talked about, you know, the enormous toll that the pandemic has kind of taken on Black women and, you know, women universally, but certainly women of color. And so I wonder if you can talk a little bit about, you know, tell us what we should be doing to help support the grassroots health disparities movement, and in particular to help provide resources and information to Black women on how we can kind of reverse this situation.
Yes, and so disparities, as you know, for Black women and for disparities generally, it exists across the spectrum, and it's really structural racism is really embedded in all aspects of our healthcare system. I mean, as Congresswoman Underwood talked about the maternal mortality, maternal health, where, you know, Black women are 3 to 4 more times likely to die of in childbirth. And also even around, we are also working around obesity. Black women in the US are chronically obese compared to other groups. About 4 out of 5 African-American women are overweight or obese. And we're also looking at other areas. For example, breast cancer. We launched it's called the Be Power Assure campaign. We launched it with Mary J. Blige, and really encourage and raising awareness around Black women and the need of breast cancer and the need to get mammograms. And we really focused on that sort of the sweet spot, the age between 40 and 50, where there's a really the highest incidence of breast cancer mortality rate, which is the highest of any ethnic group. And then, you know, also in terms of policy solutions, you know, we're supporting legislation such as the momless legislation. We're supporting legislation on the Hill around obesity, you know, which allows for the TROA Act, which allows for Medicare Part D to cover anti-obesity medications. And then most recently, 2 things. One, there's a New York Times article yesterday that talked about in terms of climate and our health and how it really impacts minority communities. And we're supporting there. We just held an HBCU listening session with the North Carolina schools talking about climate and its intersection with health. And then also with FDA, the announcement the president made today in terms of the FDA, it's going to move forward with its rulemaking process to ban menthol cigarettes, which is a big deal for us. I mean, we just also launched another campaign on HBCU campuses to really educate around tobacco. And so I think for advocacy organizations, and I'd probably be remiss if I didn't say this, Black Women's Health Affairs, we released a policy agenda where we really laid out really many of the different issues and provided policy recommendations around issues that uniquely impact Black women. And so there are like 4 pillars. One is access to quality and affordable health care, which obviously includes like the ACA, Medicaid, Medicare, diabetes, obesity, reproductive justice. We have a second pillar, which is around public health emergencies, which would be your COVID-19, which would be environmental justice issues, gun violence, tobacco. Then we have a pillar 3, which is around clinical diversity, increasing diversity in clinical trials, which we know is really important now. I mean, a lot of questions that we heard from our networks was that, you know, how many Black women were in the clinical trials for the vaccines, or for example, we have a rare disease population, how many were that had sickle cell that actually participated. And then also obviously being a graduate of an HBCU, we support increased funding for HBCUs. And then we felt that we need to add a 5th pillar to the policy agenda this year, which was social justice. So there's we look at police violence and sexual assault and incarceration. So I think really for resources that really help advocacy organizations do the work to go out into the community, to the grassroots, and actually reach individuals, I think it's paramount. And we should continue to build that infrastructure.
Now that's really great, Tammy, and you gave us a lot of good information there. I want to make sure, though, for those that are interested in taking a look at that policy agenda, is there a website that they can go to pull that up?
Yes, www.bwhi.org.
Awesome. Awesome. Thank you. And I know we'll try and include that information in the materials that we send out as a follow-up as well. Dr. Puckrin, you mentioned the zip code analysis project earlier, or made reference to the zip code analysis project. And you also talked about, which I think is a really interesting concept, this idea of managing patient risk or decreasing patient risk rather than being focused on managing the financial risk. So I was wondering if you could help us dig a little bit deeper and tell us more about how the zip code where you live in, how it can be an indicator of, you know, both your health outcomes, but as we heard Tammy reference, you know, climate plays a role in that as well. But can you talk to us a little bit more about going into depth about, you know, for those zip codes that are more likely to experience negative health outcomes, what's the financial offset that comes with that?
Sure. So the way we think about it is healthcare is a deep collaboration. We have people in this country who don't believe in collaboration, but healthcare is actually a very, very deep collaboration. And that collaboration really takes place at the local community level. It is where the patient, the physician, social services, policy, insurance, all of them come together at a moment to provide care. And basically what we try to take a look at is that collaboration, is that local collaboration, is it following evidence-based medicine? Or are there things inside of the system that are producing these poor outcomes? You know, for example, with maternal health, you could actually drill down to the zip code level and take a look at the hospitals, the physician practices, to see if we're seeing clusters of poor outcomes for women who go to a particular hospital, go to a particular practice. You can take a look at the therapies or interventions that take place. And it's not just an academic exercise. So what we do as we drill into the data, we work with practices. We literally have a team that we call them champions. We find physicians who are doing it correctly, and we take them into those communities and try to change practice procedures in order to get better outcomes for patients. It really is by the numbers. At the end of the day, this is really about the numbers and about evidence. But what happens far too often is that as systems try to manage financial risk, they decide that they're not going to follow the evidence and the science to get the best outcomes for patients. And they end up elevating their risk of the patients because they're trying to essentially balance the books. And you can see that, you mentioned sickle cell. We see that all the time with sickle cell. We see that with heart failure. We see that with diabetes, which is an absolute mess. And so the point is that we have to reorient the system. It has to be reimagined. I don't know, I'm here in Washington. I go to all of these meetings and I listen to CMS, and every time CMS comes up with a proposal, it's about payment reform. You know, that's the only thing that they have in mind is payment reform. They never set up and say, you know something, let's just take a moment to get some better outcomes for patients for once. And we think that as they turn to managing patients, that the financial risk will come along, because as we improve outcomes for patients, they don't have to go to the hospital as much, they don't have to go to the ER as much, et cetera, that we'll get the financial rewards that we're looking for. But it all happens down at the local community. That's the intersection where our policies, insurance, and care come together to get the best outcomes for patients.
No, that's, I really like what you said, Doctor, when we talk about reimagining, I think you said reimagining the system, reorienting the system, which brings me to you, Congresswoman Underwood, because as you've shared with us, you are working hard on the policy side every day and driving, comprehensive policy solutions, and working closely with your colleagues to achieve better, more comprehensive, solution-oriented policies. But I'd be curious to know, as a policymaker, what are your expectations for corporate, for the private sector to engage on these issues, and how do we incentivize, or how can we incentivize more of our corporate partners to do the right thing in this area, or to be engaged on these issues?
Well, with the Black Maternal Health Caucus, we launched in April of 2019 and had our first stakeholder summit that summer. So it was probably like June or July of 2019. So this is before the Momnibus had even been conceptualized. We had an opportunity to talk with the providers, the payers, the industries that were engaged in the larger maternal health space. So, that could be transportation companies. It could be, like people who are active in the nutrition space, right? Like, we have had the opportunity to engage really across the board with these companies. And it's been such a productive engagement because, we are able to get company data, particularly from the payers, that give us much more granular detail than we've been able to get timely from the federal partners that we have, right? And this is even after we began to have partnerships during the Trump administration with his Surgeon General, with his Secretary of HHS, right? Like, we had developed a productive working partnership. Let me use the proper words here. A productive working partnership with the Trump administration to get information. But the data that we were able to receive from private industry was extraordinary. There's an incredible opportunity for industry to make commitments, to analyze and share their data, and to be really involved, particularly in the communities that they're headquartered in. Maternal mortality is a issue that has a real geographic footprint. We are seeing clusters of deaths, higher rates of deaths, for example, in communities that have air pollution or extreme heat, right? We have a climate change related provision to address that. But there's also, before we were even using words like climate change, there were Black women-led groups that were tackling this issue in a place-based way for decades, doing this work on their own, trying to raise the flag with their local health system to say something's wrong. But guess what? Health systems are not necessarily doing the data analysis in that way to catch those kinds of trends, right? And many of the payers have the data, but they weren't analyzing it in that way. But now, if we can all put a bright spotlight and say, hey, let's try to tackle maternal mortality in Chicago. Let's try to tackle it in Peoria, or let's try to tackle it in Rockford. Let's try to tackle it in, the Bronx, or, there's interesting work happening in New York City. We're really excited about it. Those companies can be great, great, great partners in that really local work, which 9 times out of 10, I would even say 10 times out of 10, is not even partisan because it's coming from the community. It's coming from the grassroots. It's coming from providers who've had enough. It's coming from, that family member, right, that is there to care for a family after the mom has died. And so I say that to say there is a tremendous opportunity for any company or association, right, that represents kind of a larger community of industry to be involved without feeling the pressure of having to bear hug the whole Momnibus or bear hug the whole issue. You can take a topic and just own that space. You can take a geography and just own that space. We welcome your participation.
No, that's really good, very insightful. I will say this, when you say, you kind of brought me back to all things are local, right?
Yes.
And to start and to get invested in sort of where you are and in your community, which, Tammy, this is what this raised, what the Congresswoman's comments raised for me, which is that, you are really, you and the Black Women's Health Imperative, Women's Health Imperative are really at the center of where the rubber meets the road in terms of being in contact with people in the community on the ground. And, almost all of us are either employed in some way or engaged with some sort of civic organization. Can you talk a little bit about what we individually can do to help spark and ignite and fuel the grassroots movement as it relates to the health disparities movement? What can we do as employees to encourage our leadership to engage on these issues? What can we do as members of the community, Tammy, to get involved and to say, hey, this is an issue that matters to us?
I would say sort of the first place would be, a lot of corporations have, well, first for companies to make sure you have a open and safe space for employees. But a part of that, a lot of companies have the employee resource groups. And so going to those employee resource groups and even taking an issue and talking to, folks at your company or organization, but then also collaborating. So for example, we have several companies that come to us and they say, for example, are working on something around, maternal mortality or diversity in clinical trials. And they want to collaborate with us. There's also like the CEO Racial Equity Council. So I think those are ways, identifying as a collective, as an organization or as a collective group on issues that that can help the advocacy organizations amplify. And quickly, the clearest example, one of the examples we're working with now is BWHI. We're leading a Rare Disease Diversity Coalition. And that consists of the American Medical Association, the National Medical Association, which is the Black Physicians, the National Black Nurses Association, and Hispanic Medical Association, also the Asian Pacific Health Forum, as well as industry, the Everlife, NORD, some of the pharma industry, also foundations, the Chan Zuckerberg Foundation. And we're coming together to really talk about what are ways that we can alleviate some of the challenges that minorities face in rare diseases. And so yesterday we had the president of Howard University spoke to the group just to talk about how we can work with, for example, HBCUs, HBCU medical schools. But I would say, definitely for employees of companies, it would be for us very helpful, I think, to come to us and help amplify some of our issues, such as the increasing diversity in clinical trials. And I do agree. I mean, some of the research, the data that you have is just so very helpful because companies are really focused in and looking at those issues. And so providing that as a resource to kind of come up with a collective solution is just very helpful.
All very good pointers, and you sprinkled some really good breadcrumbs there for us all to follow on how we can get engaged and make sure that the organizations and the companies that we're involved in are also getting engaged and lifting their voice on that. Dr. Puckrin, I would love to return back to kind of, we talked about a little bit earlier in the conversation, we talked about the CDC recently identifying racism as a public health threat. I know this is probably, that declaration was probably not news to you, but I wonder if you can share with us how that helps inform the work that you're doing at the National Minority Quality Forum. Has it helped you gain more traction, or has it helped amplify your message more? If you could just talk a little bit about that and what the practical impacts of that as you create policy and move to do the work in this area.
So it really helps to level set some of our history. So, part of what happened, unfortunately, at the birth of this country, there was a decision made to enslave African Americans. And I know that takes us way back, but it's really important because what that was about financial risk. The founding fathers, they were committed to democracy and all man is equal, but they realized that they needed labor. and they needed to corral labor. And so essentially financial risk took place over patient or life risk, right? And that's had a deep impact on American history. And even our healthcare system, the modern healthcare system gets started around in the 1940s with World War II, where the employer-based system comes up because the war caused the government to say that you couldn't induce workers by wages. And so companies decided to use healthcare as an incentive to bring people in. But at that time, segregation and inequalities were accepted by law and practice. It's really 1970s before we have desegregation of hospitals. Medical societies were segregated. And so that begins to come down in the late 80s and 90s. But the legacy system was still there. The inequalities were never addressed. The racism that was in that legacy system, and even more importantly, that whole presumption that financial risk is more important than life and patient risk is all built into that history. And so when CDC starts to unpeel racism within the healthcare system, they're opening us up for a deeper conversation about what we value, right? That is the most important question in this country. What do we actually value? Do we value money, or do we actually value the lives of the people? And the thing I would remind everyone as a historian is that inside the Declaration of Independence, it says life, liberty, and the pursuit of happiness. The actual original words were preservation of life. Right? That was what we all agreed to collaborate together to preserve life. That was the prime directive that we gave up on. And now we're coming back to this point where we now have to pull that back in and understand it in the context of our history. That's the conversation that we're having. Politically, socially, it's all over the place. And I think what America becomes weighs in the balance. And so this conversation about disparities is not just limited to healthcare. It is part of the broader conversation about what America is. And I think what's driving it, obviously, is the demographic shift, because the minority populations that were disenfranchised and couldn't get quality health care are now, through their political voice, through their elected officials like Congresswoman Underwood, are coming in and saying, we have to change this system. We have to reimagine it, because that legacy system was really built around inequalities. And I think that's the real deep conversation that's going on that we're all working to. There is no reason why we should be putting American citizens at risk in order to preserve our economy. The way I would say it back to you is, do we want our biology to support our economy, or do we want an economy that supports our biology? And I think we want an economy that supports our biology.
I love the way you weaved in both your history and the historical perspective and dropped some science on us, as well as making sure that we understand that our choices, our economic choices, have impact on our livelihood. And when you talk about the preservation of life or the life, liberty, and pursuit of happiness, that at the core of that was the preservation of life. And I think that's an important anchor as we continue to have this conversation nationally. Congresswoman Underwood, just to piggyback a little bit about the CDC's acknowledgement of structural racism as a part of the health policy discussion. I'm interested in how that may have positively or negatively, or if it at all has impacted the partnership that you and so many of your colleagues have been able to, your partnership with the CDC. Has that opened up more possibilities for how these issues can be addressed?
Well, I just say, I'm a nurse. I approach my work from that lens. And as healthcare providers, I think that we have long come to that conclusion. What we have more recently, and this has just really been a couple of weeks now that the CDC has now said that part out loud. And we're grateful for it, but it has not, in any way reshaped or reimagined a working relationship that we have with that agency. Obviously, CDC has been, all in on COVID. And I think that as, the recovery comes into focus and we're able to take a broader look at the full landscape of healthcare and the status of healthcare across key demographic groups, including people of color, in the post-COVID timeframe, I think that we'll really have an opportunity to have this kind of conversation with a level of candor. And I hope that they are willing, this is what I was trying to say at the beginning, I hope that folks are willing to have this conversation with that level of candor about broader healthcare issues that we have become more accustomed to having in the context of the pandemic, right? There was no looking away. The data were stark and they were so clear, and it was happening over and over and over in states and communities across this country. I just earlier today was speaking to the 100 Black Women Coalition, and I just had to acknowledge, right? Like, as Black women, we have been grieving for a year plus. I mean, I still am getting emails of death notices from my sorority, from my church. I mean, it has not stopped. And I think that our community has just been hit time after time, wave after wave. And so, we have to decide how to move forward. And it's my hope that it's not just going to be the Black Caucus, right? That, pushes people to say, like, let's have a different future. And, I am encouraged that at least we're using rhetoric that, more closely reflects the nature of the crisis that we face as a country.
So what I heard you say, Congresswoman, is you are waiting for them to walk the walk as well as talk the talk, and that you're looking for.
It's still an emergency, right? So, like, I'm not going to diss them, and they're doing great work. I'm excited about well, her name's Rochelle. I don't know what her last name is. I'm excited about her leadership, but I'm ready for my meeting because I got a long list of requests.
Well, look, I look forward for you giving us a readout in whatever way is proper for that meeting, because we are definitely looking forward to you carrying the banner on these issues, and also making sure and challenging all of us to make sure that we don't return to normal, as you said, right? Not to put the blinders back on, but to keep the spotlight on these issues and make sure that it's now a part of our normal lexicon, rather than just for this moment or just in this crisis. Which brings me to you, Tammy, which is, you mentioned a lot of the opportunities that you've had to partner with HBCUs. And can you talk about what partnerships with HBCUs can look like in order to help keep the momentum going, to highlight all of these issues around healthcare and policy? There also, you mentioned Dr. Frederick, there are also HBCUs that have played a tremendous role in terms of educating and producing African-American doctors. So can you just talk a little bit about what you see in terms of the role that HBCUs can play as a part of this education campaign, but also in terms of building momentum?
Absolutely. So HBCUs play a critical role. I think what you see now in the advocacy community, as many groups are developing their campaigns, and even sort of to step back in terms of Black women really being involved in making sure the current administration looks the way it looks now. And so many of them want to also be a part of many of the policy changes that are implemented. And from HBCUs, all the way, to even your older population. But for the HBCUs, for us, we're working with them many of the health disparities, they impact, younger Black women, men as well. But utilizing that platform, and then as you talk about HBCUs, within the HBCU medical schools, Meharry, Howard, Morehouse, Charles Drew is in there as well. As you talk about those, I mean, just the role that they play as trusted messengers in the community. And so even for the advocacy organizations, you have to even tailor your messages, the messages that you have in teaching for us, like in teaching advocacy and resilience and empowering younger people to go their members of the Congress or their local elected officials. Many of us either use different messages for that. And really, when you talk about the role that HBCUs and younger people can play, I mean, even as I talk about like Congressman, my old boss, Congressman John Lewis, I mean, he wasn't, 40 or 50 advocating. They were all younger people who were sort of advocating for change. And so, utilizing that as we look for policy changes around health disparities and really teaching them how to be, advocates is key.
So with that, I'm going to, Congresswoman, do you think we can count on the Congress and the administration to bring about some more investment within our historically Black colleges and universities as a part of whether it's the American Families Plan or as we look forward towards the future?
Well, we know that the president wants to do it. And we know that the House is down. So the question is about the Senate. And I don't presume to know anything about what they will do. Not in this environment. But what I can tell you is that the politics of investing in HBCUs are very clear. And that is something that I think colleagues on both sides of the aisle understand. This is also very much an economic issue. And I hope that we continue to see engagement, not just from the larger Black community, but from like alumni and students that can speak very directly to these key senators and let them know how these dollars will be used, right? Like, I think that, I am not the expert on HBCUs, so like, please don't come at me if you don't agree with this statement. But I do think that to a certain extent, the HBCU funding has become kind of like a proxy for investing in Black people. And I think that we may find additional success if we actually focus on what the HBCUs do and what the outcomes of those investment dollars are. And I'm not saying change the advocacy strategy because it's brought us this far and I understand that. But once you start, I think when we start talking about a different threshold of dollars, we need to be able to have a different type of conversation. I'm not seeing that conversation led by the people impacted. I'm seeing that conversation led by folks who treat HBCU giving like they do philanthropy. You know what I'm saying? It's just like very different. And I think that we have a special moment to really grow the impact of these important institutions within our community. And I think that, it's within our reach. We just have to change the tactics a little bit.
No, I think those are all useful, very useful points. We're at the point, we have lots of questions flowing in from the chat and from the folks that are watching and who've joined us. I'm going to throw a couple out here for each of you to sort of respond to. Let's see if I've, forgive me. So the first question that we have is kind of, and I'll throw this out here for kind of a round robin for everyone's sort of response, but it's two questions that I'd like you to kind of address collectively together. So can you help give our audience an opportunity to understand how there might be an implicit bias around pain management when it comes to people of color, particularly African-American women, and help, what can we do collectively to help educate the health community around that and around the particular bias that may exist around pain management for people of color? And then also the next question is should we be incorporating, implicit bias training in our medical schools and or in our healthcare education opportunities? Congresswoman, I don't know, I know you're a nurse. I don't know if you want to lead us off on that one.
Sure. So, let's be very clear about the terms we're using. There's implicit bias, which is, as a clinician, I don't really know that I am treating patients differently and that I am bringing some preconceived notions about, in your example, pain, but just their experiences and how they present themselves to that clinical interaction. Then there's explicit bias, which is racism. Both exist. And we need to be serious about addressing both. The mommy bus addresses both. Okay. And so the implicit bias is something that I think people are much more comfortable with, particularly when it comes to industry. They like to talk about that, and I think that's fine. And there are evidence-based trainings that, health systems can adopt in order to coach and teach their clinical staff to be better clinicians, have better clinical interactions, and have better quality outcomes, and not have racism, particularly with that, not have implicit bias in those clinical interactions. That can happen by like a series of trainings, right? That is not a 1-hour webinar, let's be clear, right? For one CEU, that is not what we're talking about, but we are talking about that there are these training curricula. Explicit bias is different. The tools that we have to address that is different. And part of it will involve confrontation, calling out. It will involve cultural shifts, and it will involve, some separations. Okay, everybody, we have to decide if we want to accept that within our healthcare system. Because I can tell you what, systemic racism is why we have this maternal mortality crisis in this country. And we just have to be clear about that. So should implicit bias training be in medical school? Yes, but we also have to be clear about explicit bias and racism, right? Like if you only tackle the implicit part, you are not going to save all the lives that we know that we need to. We will not be ending these disparities. And so, I think
there it is.
We're in a moment where we can acknowledge that and find it within ourselves to, move forward.
Absolutely. And so I know we're coming towards the end of the time. We want to be respectful of everyone's time that's with us. And thank you, Congresswoman Underwood, for making it plain and continuing to make it plain for us. Dr. Puckren, you have some thoughts that you want to share on those two questions, or maybe in response to the Congresswoman as well?
I think the Congresswoman stated it absolutely correctly. That there are really two domains. I think explicit bias has to be dealt with directly and forcefully. We see what happened in the Asian community with COVID and the outrageous behavior that went on there. That has to be directly dealt with. The explicit bias is difficult, and I think part of it is training and also measuring, right? If we're starting to see bad outcomes coming from a provider that is showing differential care, the system has to be on its guard. I think those two domains have to be dealt with separately, and I think the Congresswoman is right on.
So Congresswoman, I know your time with us has come to an end, and we are also towards the end of our time together. I want to thank you, Tammy, and you, Dr. Puckren, and also Congresswoman Yu for joining us, for being with us, for raising the important and sometimes difficult issues that surround how we resolve and eliminate health disparities. I want to thank you for challenging all of us to both reimagine the healthcare system, and that we call a thing as we move through this national health crisis together. And as Congresswoman, as you challenged us, I also thank you for giving us the breadcrumbs to make sure that we don't return to normal, and instead that we continue to highlight and do the work to make health equity a reality for all of our American citizens, and that we live up to the creed that of life, liberty, and the pursuit of happiness. So Thank you so much for joining us. We will be able to share our follow-up information. You can follow us on Twitter or on LinkedIn at Invariant. And thank you so much for sharing and spending time with us for this very important discussion.